Hello and welcome everyone. I'm Dr. Peck. I'm very happy to be here and have an opportunity to share my dental experience with you. I'm really truly honored by this. I wish I can be with you in person, but obviously because of the pandemic and the virus prevents us from doing live lectures. I wish you all the best and great safety, and I hope your families are well and hopefully see you soon in person. It's an honor, privilege, and great pleasure to be here and present in this meeting. Thank you all for coming. And I also would like to express my sincere gratitude to all who have been working hard to prepare this meeting. I'm from Seoul, Korea, and the Seoul is the capital city of Korea. I trained my prosthodontic in residency program in Columbia University in the city of New York. After finishing my residency, I became the diplomat of American Board of Prosthodontics. As I finished my prosthodontic training, I moved myself to Korea, and I have been working in the Department of Prosthodontics in Kyunghee University since 2010. This is my crew, my colleagues, and we all welcome you to this great event. This is where I belong now, Kyunghee University in the city of Seoul. Please feel free to ask or share your experience through my email or Instagram, whichever is convenient for you. Now let's go back to today's topic. And today's topic that I'm honored to be lecturing with your group is All-on-4 treatment concept. And I'd like to go over the details and discuss about All-on-4 treatment. And I'd like to share some literatures and my actual clinical cases with you. The All-on-4 concept is founded on the principle that 4 implants, a combination of 2 straight anterior and 2 tilted posterior placed within the premaxilla or anterior mandible, would provide enough support to maintain a full arch fixed prosthesis. But before we go on into the details about All-on-4, let's review some basic principles about the full arch implant reconstruction. We do have many guidelines when we are restoring fully edentulous patients with implants. Many textbooks, literatures are stating that we need to place at least 6 implants to fully restore edentulous patient. If the bone is good enough to place 2 adjacent implants, just like in this picture, we can section the prosthesis instead of splitting the whole prosthesis. Sectioning of prosthesis has many benefits. The patient will easily use dental floss to maintain oral hygiene. And when the prosthetic complications occur, such as porcelain chipping, interproximal contact loss, we can easily repair the prosthesis. Let me show you one of my full mouth implant rehabilitation case. Young patient with aggressive periodontitis presented to my clinic for prosthodontic rehabilitation. This poor lady had a failing dentition, and we had to pull out all the remaining teeth due to severe periodontal disease. All the remaining teeth except second molars were extracted, and we plan to reconstruct with implant fixed prosthesis. After 2 months of extraction, all the extraction sockets were healed, and we were ready to move on to implant placement. Very conventional way, we did full mouth wax up to locate the implants regarding prosthodontic design. We first decide where the final prosthesis will be, and we plan our implants regarding the final prosthesis. This is also called a top-down planning or prosthetically driven treatment planning. We duplicated the full mouth wax-up and fabricated a radiographic stent. A CT scan was performed to check the bone volume where the implants need to be placed. We checked the bone volume with CT scan and we converted the radiographic guide to the surgical guide. 8 implants were placed in maxilla and 6 implants were placed in mandible. We placed these number of implants to section the prosthesis instead of splinting all together. After osseointegration, the temporary copings were inserted to the fixtures and provisional prostheses were delivered. Patient freely used the provisional prosthesis for 3 to 4 months, and we moved on to the fabrication of definitive prosthesis. Fixture level implant impression were taken, and full mouth wax-up were done again on the working cast. Ceramic metal prostheses were made and delivered to the patient. The patient was happy, and I was happy. We made 4 section pieces of prosthesis in maxilla and 3 section pieces of prosthesis in mandible. This is panoramic view at the day of delivery. This is 7-year recall. There were no significant findings. Bone level was good and the prosthesis had no complications. This is 12-year recall. Still, everything looks very good. And I'm pretty sure that the future prognosis is also expected to be good too. Just as you saw with my first case, if there are no anatomic limitations and if it is possible to place 8 implants, it will allow segmentation of the prosthesis, the best way to make full mouth implant prosthesis. However, increased number of implants can burden the patient with higher cost. Yes, the treatment fee will be very, very expensive. Segmented prosthesis will allow easier revision or repair and simplifies the lab procedures and helps achieve a passive fit. However, if we cannot place implant adjacent to each other like this, we cannot make the segmented prosthesis. The option to segment the prosthesis is not always available and will be dependent on the distribution of the implants. Let me show you my second case. The female patient in her 70s was also rehabilitated with full mouth implants. The bone loss was so severe that she had lost a lot of bone both horizontally and vertically. Definitely, we had anatomic limitations to ideally and prosthetically place implant. We had to place implants where the bone was and make this one big splinted implant prosthesis. Take a look at this huge one-piece framework. The porcelain was built up on top of the framework. The pink porcelain was applied for the soft tissue part. And the prosthesis was delivered to the patient. There was no prosthetic option but to make a big splinted one-piece implant prosthesis. That was because of the anatomic limitations. Of course, instead of making one big piece fixed prosthesis, we could have considered an overdenture option, but the patient strongly insisted the fixed prosthesis, not the removable prosthesis. Well, if I'm to do this case again, I would rather go with overdenture option instead of fixed option. That's because of this big horizontal cantilever inevitably made by huge, big bone loss. The clinicians make much effort to minimize the number of implants and make a full mouth implant prosthesis. Minimizing the number of implants can definitely reduce the treatment cost. But not only the reduction of treatment costs, but the most benefit is that we can overcome the anatomic limitations. Some patients have severe bone loss in posterior mandible and cannot get implant treatment for posterior molars because of the inferior alveolar nerve. But if we place implants in anterior mandible and make a distal cantilever, we can provide fixed implant prosthesis to the patient. The posterior cantilever length is reported to be a maximum of 1.5 times the anterior posterior spread. This is a case that I did in 2009. Fully edentulous patient came into Columbia University for fixed implant prosthesis in mandible. Because there was not enough bone in posterior mandible, we weren't able to place implants in these two posterior mandible areas. But because the patient strongly wanted a fixed prosthesis, we decided to place implants in anterior mandible and make a distal cantilever. We expected the final prosthesis to be like this design. I personally don't like cantilevers, and I prefer the distal cantilever not to be too much. Because we had to avoid the inferior alveolar nerve and evenly distribute the anterior implants, we decided to go with the digital surgical guide. With a CT scan and the scan of radiographic guide, we were able to plan our implants in the software. With the surgical guide, 5 well-distributed implants were placed in anterior mandible, and I immediately loaded with provisional prosthesis. Existing denture was converted to immediate loading provisional restoration. Titanium temporary copings were attached to the fixtures, and the existing denture was hollowed out and reconnected to titanium copings with acrylic resin. After osseointegration, we started to make definitive prosthesis. First, we took the fixture level impression. A pickup open tray impression was taken with the splitting of impression copings for accurate and passive fit of the prosthesis. I personally mostly use dental floss to connect impression copings, and then I put pattern resin on dental floss. This is to make the most accurate implant impression by minimizing the shrinkage and distortion of VPS impression material. And when making working casts, I don't pour stone at one go. I use 2-pour technique by which I pour the stone by minimum amount to engage the implant analog first, let it set, and I pour the second set of dental stone. This technique is to minimize the expansion of dental stone. In the final working cast, the pattern resin was made for zirconia framework. In this case, instead of using wax, I used pattern resin to design the zirconia framework. The pattern was scanned and milled into zirconia. Zirconia framework was made, and because I splinted the impression coping and did 2-pour dental stone, the passive fit was achieved and it was verified in the patient's mouth. And then porcelain was built up to maximize the aesthetics. Very nicely done, and the patient was really happy. Because it was a complete denture in maxilla, I'm pretty sure that the prognosis of distal cantilevers will be very good. Many studies have been published regarding the number of implants in fully edentulous patients. However, little scientific evidence exists to indicate the minimum number of implants, recommended implant diameter, length, and ideal position. When the cantilevers would get too long, more than 4 implants are indicated. If the reduced length implant, which is shorter than 6 millimeters, and if the reduced diameter implants, which is narrower than 3.3 millimeters, are used, more implants should be considered. Let's go over some cases. This case was done in the year 2008. The patient presented to me saying that I don't want any removable prosthesis. I want the fixed implant prosthesis. Because the patient had very strong muscles and heavy occlusal forces with a big masseter, I decided to place 6 implants in both maxilla and mandible. First, I planned the location of implants in the software and decided to go with the digital guide for accurate placement of implants. This is a surgical guide before the surgery. This was obtained from virtual planning in the software. I placed my implants with the help of this digital surgical guide. And at the day of surgery, existing dentures were converted to fixed interim prosthesis. Existing dentures were converted and immediately loaded right after the surgery. This case was done in 2011, which is about 10 years ago. And the patient wanted to get fixed implant prosthesis because he could not use mandibular denture at all. First, we took the preliminary impression with alginate to decide the number and location of implant placement. We set up the denture teeth to relate the position of implants with future implant prosthesis. Because the patient was a bit of financially compromised, we decided to place 4 implants instead of 6 or 8 implants. 4 well-distributed implants were placed in edentulous mandible and immediately loaded. Because the patient had removable partial denture in maxilla, 4 implants were expected to support the lower fixed implant prosthesis without any complications. After 3 months of osseointegration, screw-type full contour zirconia prosthesis was fabricated and delivered. Now we are on a 10-year follow-up, and the patient is using this 4 implant supported prosthesis very well for 10 years. We were able to place implants on posterior mandible because there was no anatomic limitations. But what about this case? In mandible, this patient had severe anatomic limitations to place implants. Yes, there was not enough bone in posterior mandible because of the inferior alveolar nerve. And in maxilla, there was a sinus problem to place implants in this posterior area. Therefore, we came up with an idea to avoid sinus problems by tilting the distal implants. By tilting the distal implants, sinus problem can be avoided, and they allow a reduction of the cantilever length and provide additional distal support to the prosthesis. Sinus elevation or sinus grafting is very challenging not only to the patient, but also to the dentist. It requires much practice and training to the dentist, and it requires higher treatment fee and post-op swelling and discomfort to the patient. So if you can place implants without doing any sinus grafting, it has benefits both to the dentist and the patient. To minimize the treatment cost and to avoid the sinus grafting, the number of implants can be reduced to 4. This all-on-4 concept is founded on the principle that 4 implants, a combination of 2 straight implants and 2 tilted posterior implants placed within premaxilla or anterior mandible, would provide enough support to maintain a full arch fixed prosthesis. The skepticism of this design has many clinicians shy away from this procedure. If 2 implants support 3-unit bridge, how could 4 implants ever support a full arch prosthesis, especially when some are tilted? The answer lies within the biomechanics of how these implants are strategically placed, coupled with prosthetic design. As I just mentioned, this all-on-4 concept is quite useful when we face anatomically compromised patients, financially compromised patients, and medically compromised patients. Anatomically compromised patients are the patients who have sinus issues or inferior alveolar nerve issues. Financially compromised patients are the patients who cannot afford many numbers of implants. Medically compromised patients are the patients who cannot withstand the rigors of bone grafting procedures. This was very, very interesting case. A 55-year-old female patient presented to Columbia University with failing dentition. Her chief complaint was, I want some implants so that I can chew and eat food. Her maxillary prostheses were ill-fitting and lower posterior teeth were missing. The existing prosthesis did not look good at all. Not only the failing existing prosthesis, but there were some weird screws on the posterior mandible. I was very, very shocked when I saw this panoramic view. There were 2 big, long screws on posterior mandible, and these 2 huge screws were penetrating right into the nerve. I had a thorough consultation with the patient and her husband. I talked with the patient and asked about the screw. This patient was from Dominican Republic, and according to the patient and her husband, the dentist there did a hip bone graft for implant placement. I was very shocked. The previous dentist took the iliac bone and fixated with these 2 screws. I'm pretty sure that the previous dentist had not that much knowledge about the anatomy and the nerve. The patient had a total numbness on the lower lip and anterior mandible. I felt really sorry for this poor lady for her loss of sensation. First, I decided to remove these 2 bad screws, but none of dental and medical drivers were fitting into the screw. I couldn't take the screws out. But by the last hope, I grabbed the driver from the toolbox, and the Phillips driver was fitting into the screw. I had absolutely no idea what kind of screws these were. Maybe these were the screws that the carpenters use. I was very, very disappointed with the previous dentist. Fortunately, we were able to remove the screw on the right, but we couldn't take the left screw out. Inevitably, left screw was decided to stay and sleep in the bone because we were worried about future complication if we try to take this broken screw part out. This broken screw part was totally osseointegrated into the bone. But the most challenging part of this case was that the patient wanted implant fixed prosthesis. We had to place implants in this poor lady's mouth again. A full contour wax-up was done, and after thorough treatment planning, we decided to extract lower anterior teeth and place all-on-4 implants. We decided to do an all-on-4 to this poor lady, and lower anterior teeth were not that bad, but because we couldn't place any implants in posterior mandible, we had to intentionally extract all lower anterior teeth. After taking the lower teeth out, we placed 4 implants in anterior mandible. For maxilla, destruction osteogenesis was done with big bone grafting. And then 7 implants were placed in maxilla. After osseointegration, screw-type fixed implant prostheses were fabricated in both maxilla and mandible. And the prostheses were delivered to the patient. I was happy with the result, and the patient was very satisfied that she now has a fixed implant prosthesis. We are now on 12-year recall, and no complication has been reported. Not always, but in some particular cases, we can maximize the benefits of this all-on-4 technique. Now I'll go over some background literatures about all-on-4 technique. This is a well-written article by Chan and Holmes. And 2 angled posterior implants, when combined with 2 straight implants, can have similar rates as traditional straight implants when splinted together using only anterior jaws. Splinted implant full arch prostheses are biomechanically sound with marginal bone height. And this treatment concept shows high degree of predictability from 92% to 100% success rate. The all-on-4 technique has evolved from original work of Dr. Brennemark and his colleagues in 1977, whereby they utilized 4 to 6 vertical implants placed within the anterior segment of edentulous maxilla and mandible, cantilevered to accommodate a full arch fixed prosthesis. Posterior bone grafting, sinus ridge augmentation before implant placement can be an alternative. However, additional surgeries, costs, extended length of treatment, and comorbidities precluded others to become innovative to circumvent these procedures and problems. In an effort to improve implant position and decrease the cantilever length, the concept of angled distal implants was studied. In maxilla, we have to avoid the maxillary sinus by angulating the distal implants. And in mandible, inferior alveolar nerve should be avoided. These are the clinical recommendations from literatures. Minimum number of 4 well-distributed implants are recommended to support a 1 big piece full arch fixed prosthesis. However, we have to consider future implant loss or complications when choosing implant number. Additional implant placement can provide more options when the implant loss or complications occur. The big advantage of all-on-4 technique is that we can avoid invasive bone grafting. Grafting procedures are very, very invasive and challenging, and increased level of clinical skill and much experience is required. The most important factor that I consider when I do all-on-4 case is this parafunctional habits. There should be no parafunctional habit when I do all-on-4 case. The bone width should be at least 5 millimeters to accommodate implant fixtures, and the bone height should be minimum 8 to 10 millimeters. Implant length is recommended to be at least 10 millimeters for maxilla, and angulation is about 30 to 45 degrees, but I feel more comfortable with less angulation, which is about 20 to 30 degrees. I prefer the angulation of distal abutment to be a little less and add a cantilever pontic instead of providing more angulation. This is a diagram of all-on-4 concept rationale, the 4 immediate function implants supporting a fixed prosthesis with a minimum of 10 teeth in the provisional prosthesis with no cantilevers, and a maximum of 2 cantilever teeth in the final definitive prosthesis. First, the guide plate is inserted to check the angulation of distal implants. The starter drill is 30 to 45 degrees to the guide, and note the hole into the interior wall of maxillary sinus. And posterior implants was inserted at 45-degree angle. The drill is 30 to 45 degrees positioned to the guide for posterior osteotomy. 4 implants, both in maxilla and mandible, were placed and immediately loaded. This is a clinical photograph that shows provisional prosthesis conversion with existing mandibular denture for immediate loading. 30 or 17-degree screw abutments were placed at the posterior sides, and straight or 17-degree screw abutments were inserted at the anterior site so that they emerge toward the opposite surface of the denture. Emergence of abutment towards opposite surface is very nicely formed. And before immediate loading, implant torque should be checked. They have to be greater than 35 Newton centimeters. And confirm the abutment seating with a radiograph, and then torque the posterior abutments. And then place a protective healing cap on these abutments and suture the surgical site. And then VPS impression material or fit checker was used to index the denture to locate the multi-unit abutments. This is the tissue surface view. An adequate amount of space should be created with an acrylic burr in the denture where index markings are present. And then we remove the protective healing cap and place temporary coping onto the multi-unit abutments. Adequate thickness of acrylic is needed to prevent fracture. Therefore, we have to provide adequate clearance. Adequate clearance is circumferentially needed around titanium coping and the denture. Lute the titanium coping with acrylic material. Lute the tissue-bearing surface of the denture to the titanium coping with acrylic. But we have to check the occlusion to be coincident before luting with acrylic. When the material sets, excessive temporary coping flush with denture level needs to be reduced. Provisional prosthesis is inserted with screws at 15 Newton centimeters, and the screw access holes were sealed with the material. I mostly use the Teflon tape and composite to fill the screw hole. And bilateral groove function occlusion with 1-tooth cantilever maximum was provided. And lastly, the patient was recommended with the soft diet. The success rate was reported by Duello in 2012. From many literatures, maxillary implants have a cumulative success rate from 92.5% to 100% in a 1 to 7 year span. Mandibular implants with 1 to 10 years have a cumulative success rate from 93.8% to 100%. This is another study by Dr. Malo in 2011. The authors conducted a study to document long-term follow-up of the All-on-4 treatment. The success rate was quite high. It ranged from 93.8% to 94.8%, and these numbers are from 10 to 11 year follow-up data. This retrospective clinical study by Lopez included 111 edentulous patients. The outcome measures were implant and prosthesis survival, marginal bone loss at 5 years, and the incidence of mechanical or biological complications. The implant cumulative success rate was from 94.5% at 7 years, and prosthetic survival was 97.8%. The average marginal bone loss at 5 years was 1.3 millimeters overall, but the most interesting part of the bone loss of axial implants and tilted implants. 1.27 millimeter bone loss for tilted implants and 1.34 millimeters bone loss for axial implants. There was less bone loss in tilted implants. Within the limitations of this study, it is possible to conclude that this treatment modality for complete edentulous jaws is possible with high long-term survival outcomes. Bruxing and smoking habits had a negative impact on implant failure, mechanical and biological complications. Then what about the contraindications for All-on-4 treatments? Multiple investigators recommend avoidance of patients with severe parafunctional habits such as bruxing and clenching to prevent future prosthetic and implant-related complications. Additionally, Lopez and his colleagues have found 7.2% of patients with bruxism leading to peri-implantitis resulting in failures. As for final prosthesis, detachment of veneering material is the most common complications. This was remedied with repair and occlusal adjustment. Increased occlusal force and loss of proprioception are thought to be the contributing factors, and patients need to retain their bite strength. Now let's go into the details about myth of All-on-4 treatment. When I do this kind of All-on-4 lectures, there are many overlapping questions that the audience asks. I have prepared frequently asked questions. My first question is, what is the current cantilever trend? In 2005, Langert's early calculation for All-on-4 concept showed cantilever length for the mandible to be about 2 times AP spread, but it was reduced to 1.5 times AP spread for the lower arch and limited to 6 to 8 millimeters for the maxilla. Complications associated with long, lengthy cantilevers can lead to either prosthetic fracture and screw loosening. Recently, a provisional prosthesis, a 4-year clinical retrospective analysis by Dr. Drager indicated cantilever length should not exceed 1 tooth size, while the final definitive prosthesis must have cantilever length, anterior-posterior spread ratio less than 1, When keeping the ratio at 0.9, he reported that less than 1% complication rate with only one denture-based fracture. My second question is, what is the recommendation for occlusion? We found a variety of occlusal designs for provisional and definitive prosthesis. Most investigators choose mutually protected occlusion, whereby the posterior teeth during sensory occlusion disallow the anterior teeth to have any contact, and the reverse is applied during lateral excursive movements for the posterior teeth. The most important points to remember about occlusion include the following: the mutually protected occlusion, minimal or no cantilever on provisional prosthesis, and lateral excursion should be canine guidance or anterior guidance, and final prosthesis should be minimum of 10 to 12 teeth per arch. Next question is, does implant size really matter? Various implant diameters and lengths are offered by manufacturing companies with narrow and wide implants. Narrow implants are defined less than 3.5 millimeters, and wide implants are defined to be greater than 4.5 millimeters. And 8 millimeter or less length implant is considered short. A 7-year retrospective analysis of immediately loaded implant full arch provisional prosthesis by Nademeyer and his colleagues in 2017 found statistically no significant differences in implant survival rate between the different implant diameters. And he also found no significant differences in different lengths, either 8 millimeters, 10 millimeters, 11 millimeters, 13 millimeters, 15 millimeters. In addition, marginal bone loss for axial and tilted implants was identical, with both recorded at 1.3 millimeters in 5 years. Another retrospective study by Babush and his colleagues in 2016 reported that narrow, regular, and wide implants, they all had cumulative implant survival of 99.8% at 3 years. The last frequently asked question is that, does All-on-4 and All-on-6 matter clinically? In a recent 5-year randomized control trial by Tallarico and his colleagues, the All-on-4 group fared slightly better than All-on-6 group in implant survival, 98.75% and 95%. However, All-on-4 group had more technical prosthodontic biological complications. Overall, there are no clinical or statistical differences in marginal bone loss between All-on-4 and All-on-6. Complication rates or worsening peri-implant conditions. Now I'm going to mention about simple and digital transformation in All-on-4 technique. Back in old days, to tilt the distal implants, we used to use this guided plate to calculate the angulation. This is the slide that I showed you earlier. We used to manually calculate the inclination of distal implants. But now in the year 2021, we do have many digital tools. We have CT scan, we have desktop scanner, we have intraoral scanner, and we do have many milling or printing machines. We have many tools that can make this implant process very easy. Either CBCT or intraoral scan alone is not enough. CBCT is missing two important components. There's no soft tissue information. There's no prosthodontic information in CBCT. So we had to find a way to combine the data, one of which, of course, is to use the intraoral scanner in order to surface scan the external structures. And by using data fusion, we can combine different data sets. We combine CT data with intraoral scan data and virtually design the implant placement. With CT scan and intraoral scan or desktop scan, we have much information about the bone, teeth, and soft tissue. From these information, we can virtually design and virtually place implants in the software prior to surgery. From the virtual planning, we can easily fabricate the surgical guide, which will direct you to exact implant placement. With the help of this surgical planning, we can visualize the nerve, we can plan our implants, and we can detect the nerve and locate our implants without damaging or hurting the nerve. With this digital surgical guide, we successfully place implants without damaging the nerve. We can utilize this digital guide not only for the conventional implant placement, but also for All-on-4 implant placement. Fully edentulous patient in her 50s came into my office for implant prosthesis. There were two implants in mandible, but the hex part was damaged. We had to take existing implants out and place new implants. However, there was not enough bone in posterior mandible to place implants. Therefore, we decided to place implants in anterior mandible and strategically tilt the distal implants. With CT scan and various digital tools, we were able to virtually design the implant placement via tilting the distal implant. Distal implants were tilted intentionally. Intentional tilting was to avoid inferior alveolar nerve and make the screw access hole to the occlusal surface of first molar. Look where the screw hole will be. It'll be at the center of the first molar. This was designed to minimize distal cantilever. This is how we planned All-on-4 implants in mandible. Virtual implant planning was done both in maxilla and mandible. And the surgical guide was fabricated, and now the surgery is ready. Two existing implants were extracted, and surgical guide was strongly fixated, and 4 implants were placed. I first placed the back implants and moved to front implants. If you place implants, if you start from here and go one way around, the surgical guide will be lifted a little when you're about to place the last implant. So I place implants, one here, and the second one will be this one, and the third one will be this one, the last one. Maxillary surgical guide is also fixated, and 6 implants were placed in edentulous maxilla. The same sequence, I first placed the right middle implant, and then I placed the left middle implant, and then the right posterior implant, left posterior implant, and anterior implants. I always do a zigzag placement to maximize the stability of the surgical guide. This is post-operative intraoral photograph, and this is the post-operative panoramic view. A total of 10 implants were placed, and all-on-4 concept was applied in mandible. Implants were placed just as we have planned in the software. After osseointegration, we began to make the prosthesis. Custom individual tray was made to take the fixture level impression. Impression copings were connected with dental floss and pattern resin. And to minimize the shrinkage of pattern resin, I cut the splinted pattern with a thin disc and reconnected the splinted pattern. Fixture level impression was taken with a custom individual tray, and working casts were fabricated, and interocclusal record was taken with maxillary provisional restoration and mandibular fixed bite block. This is the full contour wax up, and take a look at the very nice location of screw holes. This is a lateral view of full contour wax up in maximal intercuspal position. And canine guidance was provided as an occlusal scheme. Full contour wax up was cut back for porcelain buildup in anterior teeth. Posterior teeth were made of full zirconia, but with some porcelain buildup for anterior aesthetics. This is the occlusal view of the zirconia framework. This is the definitive prosthesis after porcelain buildup. The patient was very happy with the result, and the prosthesis was delivered to the patient. Now we are on 8-year follow-up, and it is functioning very well without any complications. Bone level is still good, and the prognosis of this treatment is expected to be good for many more years. Let me show you another case with all-on-4 technique. A 75-year-old female patient presented for full mouth reconstruction. Only left cuspid was left, but it was failing due to the horizontal bone loss. We decided to extract the tooth and planned to place implants. This is a pre-op intraoral view of the dentition. The tooth was extracted and 4 implants were placed in anterior mandible. 4 NR-line implants were placed. Because the ridge was very thin, NR-line implants were selected, and posterior implants were placed with distal inclining. To make the soft tissue around the implant thick and healthy, additional free gingival grafting was done, and the prognosis of implants depend on the soft tissue thickness and the amount of keratinized tissue. By doing the free gingival graft, the soft tissue will offer strong resistance to gingival inflammation and periimplantitis. This is post-op panoramic view, and it shows the success of all-on-4 implant placement. Soft tissue is looking good and healing very nicely. The existing dentures were duplicated for custom impression tray. Final impressions were taken to make another set of provisional dentures. CAD designing was used to fabricate provisional dentures. The base was designed and the denture teeth were designed on top of the denture base. Denture base and denture teeth were milled and fabricated. These two parts were bonded with resin cement. For anterior aesthetics, the pink resin was built up for the gingival part. Nice looking and well-functioning provisional dentures were delivered. The patient was comfortable with the provisional dentures. Aesthetics, occlusion, centriculation, occlusal vertical dimensions were checked, and everything was acceptable. Because the patient wanted a fixed restoration, after a certain period of adaptation, we decided to move on to another set of fixed provisional prostheses. Custom abutments were made and the fixed provisional prosthesis was fabricated and delivered to the patient. The patient was very happy with the fixed provisional prosthesis. And then we started to make definitive prosthesis. Inner crowns were designed and milled with titanium. Cobalt chrome framework was designed afterwards. Final prosthesis was designed in the CAD software, and reinforced pectin framework was fabricated. This pectin is a semi-crystalline organic polymer with high heat resistance, chemical resistance, and the ability to withstand high mechanical loads. The final prosthesis was made on top of the pectin framework. This is the final prosthesis. Maxillary complete denture and conus type mandibular fixed implant prosthesis. It was delivered to the patient, and the fit was very good, and patient was happy that he's not using mandibular denture anymore. This is 11-month follow-up. We can see a bit of staining, but overall prognosis is very good. And because the opposing dentition is a complete denture, the distal cantilever on mandible is expected not to cause any complications. This is 8-month follow-up radiograph. And this is 1 year and 3-month follow-up panoramic view. As we can see from previous cases, All-on-4 procedures have many benefits by reducing the number of implants. This is the last clinical case that I'd like to share with you. 69-year-old male patient, and there were 5 root copings and overdenture in maxilla, but the root copings were failing with a severe recurrent caries. The mandible was edentulous, and we decided to place all-on-4 implants in mandible. 4 implants were placed according to all-on-4 protocol, and these maxillary copings were decided to be extracted. Maxillary root copings were extracted and 4 implants were placed in maxilla. Because the bone was not sufficient in maxilla, we did a bit of ridge splitting and bone grafting with osteon 3. Aniline implants were placed in a thin ridge. Osteon 3 collagen was applied and collagen grafting was done. 4 implants on both maxilla and mandible, a total of 8 implants were placed. And this is the post-op radiographic view. This is a clinical photograph 3 weeks after implantation. Grafting site and soft tissue look quite stable and healthy. During the healing period, interim dentures were adjusted and used. After 5 months of healing and osseointegration, we were ready to make the prosthesis. We attached magnets for maxillary implants, and the denture became more stable and retentive. For mandible, we also used magnetic attachment for distal implants, and we used O-ring attachments for anterior implants to provide maximum retention, stability, and support. The patient is now using the dentures very well without any complications. Happy denture, happy patient. As we can see from previous cases, All-on-4 concept provides us many prosthetic options, such as fixed implant prosthesis and stable overdenture, just like in this case. However, we do have the drawbacks in All-on-4 concept. In clinical reality, we sometimes have some implant failures. Implant failure does not occur frequently, but it sometimes happens. Well, things happen. If we place many implants, like 8 implants, one failure is manageable. But what if the failure happens in All-on-4? Well, it becomes all or nothing. That's the biggest problem. So when we do a full mouth implant reconstruction cases, it's always better to over-engineer the case by placing some additional implants. So the number 4 is the minimum number. We have discussed many clinical aspects about All-on-4 technique. Let me briefly summarize today's lecture. The cumulative success rate was reported to be from 92.5% to 100% in maxillary implants and 93.8% to 100% in mandibular implants. These numbers mean the stability and predictability of All-on-4 technique. However, we have to be very careful about All-on-4 if the patient has parafunctional occlusal habits. I mentioned about the current cantilever trend. The cantilever length is recommended not to exceed AP spread. Cantilever length to anterior posterior spread ratio is recommended to be less than 1. The occlusal scheme is recommended to be mutually protected occlusion, and in lateral excursions, canine guidance or anterior guidance is recommended. Implant diameter did not really matter, whether it is wide, narrow, short, or long. They all had implant survival, which is about 99%. All-on-4 and All-on-6 did not matter clinically. Surprisingly, All-on-4 had higher implant survival rate than All-on-6. However, All-on-4 group had more technical and biological complications. But in terms of marginal bone loss, there was no clinical or significant differences between All-on-4 and All-on-6. This is my last slide of today's lecture. I was very happy to share my experience with you. Thank you again for your warm invitation and all the support. I wish you every success in your implant dentistry. Please feel free to ask me if you have any questions by email or Instagram, and I hope to see you soon. I hope to see you all in the very near future again. Thank you. Thank you very much for your kind attention.